So my screen is visible?
Yes, sir.
Okay, thank you very much. So you can see here, this is first I'll be talking about the bone, then the different ligaments and the muscles and the nerves and the arteries. So these are the different ways I'll be talking. So this is the elbow, anterior elbow, and you can understand, all that there are the three bones are taking part in the elbow joint. So from the above, it is humerus, and from the below, the lateral side, you are having the radius. So this is radius, this is your ulna, and the humerus is on the above. So the bony part, what you can see here, this is your what? Go on talking with me. This is your lateral epicondyle. This is your medial epicondyle. And you remember that the medial epicondyle is more prominent, more protruded, and there is a notch there. And this is your radial head. So radial head articulates with capitulum. So this is radial head. So this is your radiocapitular joint. So radiocapitular joint is basically a rounded. And then there is a depression. And that depression is known as the trochlea. And that is articulating with the coronoid process. So this joint is your ulnohumeral joint. This joint is ulnar and humeral. This is radiocapitular and ulnohumeral joint. And there is a process, this is known as your coronoid process. And there is another process on this side, that is the sublimus tubercle. And let me clear the drawing. So you can see, appreciate, there are two fossas here. One fossa is here. This is where the coronoid process and getting metastasis. So this is known as the coronoid fossa. And the radial head comes here. So this is known as the radial fossa. So when you are flexing the elbow, this is going here and this is going here. So radiocapitular joint and ulnohumeral joint. And let me clear. So anteriorly, these are the structures. Now, if we are going into the medial side, so I already told this is your sublimus tubercle, and this is the epicondyle. If I'm going for medial epicondyle, if we are going more posteriorly, so then, sorry. So this is your olecranon process. This is the olecranon process, and this fossa is basically olecranon fossa. So this is from posterior side, and the triceps tendon, triceps is three muscles together, gets attached to the olecranon process. So this is your posterior side. And if you are going to the lateral side, so this is the lateral side. So there is this is the lateral epicondyle, and there are certain ligaments are there, and I'll be showing you the ligaments now. So let me clear the drawing first. And now let me put the ligaments. So few of the ligaments are very important. So this is your synovium, the synovial sac of this elbow joint. Then is the few of the ligaments. So these are the different ligamentous complex. So let me talk one by one. First, let us go to the lateral ligamentous complex. So in the lateral side, so this ligament is the radial collateral ligament. So the radial collateral ligament has three bands basically. One is the radial collateral ligament, which intermingles with the annular ligament. Annular ligament is around the annulus, and along with that, so there is a lateral ulnar ligament. So that is also a part of the lateral ligamental complex. So let me see. So annular ligament, which will be around the radial head, then the radial collateral ligament, which intermingles with the radial collateral annular ligament, and this is the lateral ulnar ligament, which or lateral ulnar collateral ligament, which basically the posterior band of the this lateral ligamental complex. So this was your lateral ligamental complex. If I am coming to the medial side, so there is your medial ligamental complex. Medial ligamental complex again have the 3 band. So, or this is also called the ulnar collateral ligament. So this is your anterior band. This is your posterior band, fan sepet, whole is posterior band. Posterior bands forms the floor of the cubital tunnel. So cubital tunnel is here, and that forms the floor. And these are the transverse, or the also called the inferior band. So the transverse and inferior band is difficult. So transverse is inferior band, where it is getting attached. One side it is getting attached with the olecranon process. Another side it is getting attached with the sublime tubercle. Whereas the anterior band, where it is getting attached, it is attached in the medial epicondyle, and distally it is getting attached with the sublime tubercle. And the posterior band, where it is getting attached, it is getting attached at the medial epicondyle here and the olecranon process here. So basically, these are the 3 bony prominence. One side is the medial epicondyle, one side is your olecranon process, and one side is your sublime tubercle. So it's a triangle. One arm of the triangle is anterior band. One arm of the triangle is your one arm, and the base is your the posterior band, and the transverse bands is the another arm of the triangle. So just remember the triangle, and these 3 bony prominence can be very nicely seen by the ultrasound. Though some literature tells that the inferior band is almost invisible, it's difficult to see, but still with we can see the inferior band also. It's not seen in all the volunteers, but it will be seen in the many volunteers here today. So we have scanned, and I'll be demonstrating you the inferior band as well. So anterior and posterior band is easy. The difficulty is the inferior band, but somehow we'll be able to show you that bands as well. So the medial and the lateral ligamental complex, these are very important, and many times we get the problem with that. So let me just remove some of the, and that is covered by the different the joint capsule. So the joint capsule and these ligaments are in some area it is getting reinforced, and that forms this different ligamental complex. So lateral ligament complex has 3 band: the radial collateral ligament, annular ligament, and the lateral ulnar collateral ligament. And the medial is having the 3 band: anterior, medial, or the ulnar collateral ligament. So ulnar collateral ligament is 2. The only ulnar collateral ligament or lateral ulnar collateral ligament. That lateral ulnar collateral ligament is a part of the lateral ligamental complex. And medially there are 3 bands forming a triangle between the 3 bony prominence. So now let us see the different muscles. Let me attach the muscles. Okay. So, and let me also put the arteries and the nerves. Okay, so just let me reduce a little bit. So this fan sepet thing, what you can see here is it is coming from this is what? This is the biceps tendon. So from the biceps tendon, so some aponeurosis comes, which is known as either it is called lacertus fibrosis, or it is also called the bicipital aponeurosis. So here, if we are putting our ultrasound probe here in this area, what we'll be able to see? We'll be able to see 3 muscles. The most prominent muscle just below the bicipital. Let me remove the bicipital part. So let me remove this. This is your long head, and this is your short head. Remember that laterally is your long head and medially is your short head. So let me remove this bicipital. So also the tendinous part I'll be hiding. So now what we are going to see, this muscle, if you are putting the probe here, then what we are going to see? We are going to see the very big muscle is your brachialis muscle in the middle of the elbow, and below that we'll be able to see the distal part of the humerus, the cartilaginous part of the humerus. And on the lateral side, we'll be seeing the brachioradialis muscles, and on the medial side, we'll be seeing some part of the pronator teres muscle. For the three muscles, when you're putting the probe in the distal end of the humerus, we'll be able to see the three muscles. Most bulky muscle at the center is the brachialis. One side brachioradialis, lateral side, another side pronator teres. Just, along with me, you just tell and remember it. Otherwise, there is no need of reading it again. Just a little bit of recapitulation will be enough. So anteriorly, when you are holding the probe, the lower end of the humerus, how will be identifying the lower end of the humerus? By the, the undulating, curved your cartilage, the very prominent cartilage. And I can remember that how a hyaline cartilage looks. Hyaline cartilage looks like an hypoechoic black line, horizontal back line, line of along with the hyperechoic. I'll be showing you. So when you are there, then you stop there and try to find out at the middle, this pyramidal shaped muscle is your brachialis. Another side is brachioradialis. This is brachioradialis. This is pronator teres. Now on the top, what you try to find out is your three important structure. One will be this brachial artery. One will be your median nerve. And here in the middle, so we'll be able to see the biceps brachii tendon. So these three, 1, 2, 3. This is also known as the B, biceps brachii tendon. Then your artery, A, and a median nerve, BAM. So these three structures will be on the top of that. So the three muscles are seen very prominently. And on the top of that, BAM, biceps brachii tendon, artery, and your median nerve. These three are very nicely seen. And few of the other nerves also will be seen. This is your radial nerve will be seen. And sometimes this the medial antebrachial nerve also can be seen, medial and the lateral. Lateral antebrachial nerve is basically the continuation of the musculoskeletal nerve. In some patients, it is nicely visible in the subcutaneous plane. In some patients, it is difficult. I'll be trying to search if it is possible. But otherwise, anteriorly, these are the two important nerves. On one side, between the brachioradialis and the brachialis, we'll be able to find out the radial nerve. And here, on the top of the brachialis, we'll be able to see the median nerve. And posteriorly, we'll be able to see the ulnar nerve. So they are the important nerves. Let me remove the drawing. Now, let me go to the medial side. So now if I'm going to the medial side, so very important is here, this common flexor tendon. So from these, there are 5 muscles are getting attached. So what are those 5 muscles? On the top, the most superficial is already you have told that just medial to the brachialis muscle is your pronator teres. So this muscle is your pronator teres. This muscle is your pronator teres. And just after that is what is going to the radial side. So this muscle is the flexor carpi radialis. So this is your flexor carpi radialis. This was pronator teres. This is flexor carpi radialis. This is the palmaris longa. And this is your flexor carpi ulnaris. So these 4 are the superficial layer of the flexor group of muscles. And if we are removing these 2 muscles, then below it, we'll be able to see. Let me remove these 2 muscles, this pronator teres and the flexor carpi radialis. So if you are removing these 2 muscles, sorry, I have to remove the pain, otherwise I'll not be able to remove it. So this muscle, which is pronator teres, let me remove that, and let me remove that. That is your flexor carpi radialis. Then below this second layer muscles, that was our flexor digitorum superficialis. So flexor digitorum superficialis has the 2 head. In fact, between the 2 head, the one is your radial head, another is your ulnar head. And in between that, median nerve passes. Here, the median nerve is passing. So that is the second layer muscles. That also have the origin, and that also a part of the common flexor tendon. So what are the common flexor tendons taking origin from the medial epicondyle? It's very common, very popular multiple choice question. So these are from lateral radial side to the medial side if you're coming. First will be coming, let me again put all the muscles. First will be coming the pronator teres. First will be coming, this muscle is pronator teres. After that, next muscle is the flexor carpi radialis. This one, this flexor carpi radialis. After that is your palmaris longus. After that is your flexor carpi ulnaris. So let's talk with me. And remember, as I was telling, no need of reading again. So most radial side, which is going from the medial epicondyle to the most radial side, is your flexor pronator teres. After the pronator teres, next muscle is your flexor carpi radialis. After that is this muscle is the palmaris longus. After that is your flexor carpi ulnaris. And if you are removing this, then there is flexor digitorum superficialis. Flexor digitorum superficialis is the second layer muscle of the flexor side of the forearm. And after that is your flexor digitorum profundus and flexor another flexor muscles, which is going to supply the thumb. So these are the two deeper layer muscles, third layer muscles. So these are the layers by layer that is coming from your medial epicondyle common flexor tendons. So this is your lateral side, medial side. I'm clearing this and I am going to the lateral side. So I'm going to the lateral side. And lateral side, there is a common extensor tendons. So common extensor tendons here again will be when we'll be talking about the wrist. That time we'll be talking about all the dorsal compartment muscles. If you can just quick recapitulation that the first compartment muscle was, it starts with A, abductor pollicis longus and extensor pollicis brevis. These are deeper layer muscles. So these do not come into the common extensor tendons. Then there are two muscles which are superficial compartment muscles, but one of them is taking origin from this lateral epicondyle. So next two muscles, second compartment muscles are what? Extensor carpi radialis longus and extensor carpi radialis brevis. So extensor carpi radialis longus, this is extensor carpi radialis longus and extensor carpi radialis brevis. So extensor carpi radialis brevis is a big muscle, and that extensor carpi radialis brevis is the most superficial, and that is the one tendon. So one tendon, 4 tendons are there. Medial side, there is 5 tendons. The lateral side, there are 4 tendons. So the most superficial is your extensor carpi radialis brevis. And remember the second compartment, another muscle is there, that is extensor carpi radialis longus. So that do not take part in the common extensor tendons. Then come is your other muscles. Other superficial muscles are what? Compartment 3 muscle is a deep muscles. Compartment 3 muscles, we can remember, extensor pollicis longus. Extensor pollicis longus is a deep layer muscles. Then the fourth compartment muscles. Fourth compartment muscles, there is one superficial, one deep. We'll be discussing this when we'll be talking about the wrist. That time we'll be talking about this, all these flexors and the extensor tendons again. Just today learn a little bit, and next day we'll be having the detail of all these things again. So fourth compartment muscles was superficial was your flexor digitorum, extensor digitorum, sorry, and deeper layer was extensor indicis. So extensor indicis is the deeper layer muscles, but superficial layer muscle is your extensor digitorum. So after this extensor carpi radialis brevis, next the tendon, extensor tendon, which is taking origin from the lateral epicondyle, is your what? Your extensor digitorum. After that, the fifth compartment muscle is your extensor digiti minimi, and the last one, the extensor carpi ulnaris. So these 4, what are these 4 again? One is extensor digitorum, extensor carpi radialis brevis, extensor digitorum, extensor digiti minimi, and extensor carpi ulnaris. So these 4 are the common extensor tendons. So that is taking origin from the lateral epicondyle. So now, if I am coming to the posterior, again the posterior side is your one muscle, but again this muscle, this is your triceps muscles, but this one muscles have the 3 band. This is the central tendon. So from the lateral side, this is the medial side. Medial side is your long head, and lateral side is your lateral head. And below the lateral and the medial is your medial head. So medial head is basically deep, and superficial layer, The deeper layer is medial, then the central extension tendon. One side is your lateral head, another side is your long head. Sometimes you are having the confusion. So just don't make any confusion. I'm just doing another thing so that you'll be able to understand it nicely. So if I'm cutting this, there is this, I can cut this. So let me remove this and you can see this. This is your, you can see I'm just little bit expanding it. So this deeper one is your medial head. So this is your medial head. Medial head is why it is called medial head, because it is coming to the medial side and getting attached with the upper part of the humerus. This is the long head. Long head is also on the medial side, but long head is attached where? It is attached to the scapula. Which part of the scapula? Below the glenoid, subglenoid tubercle. That is where the long head is attached. It is long, so it is going longer and it is going into the scapula. And this side is the lateral head. Lateral head is again attached to the shaft of the humerus. And here will be the central tendon. So central tendon, one side is your lateral head. This is your lateral head. This is your medial head, whole is medial head. And this is your long head. So long head, lateral head, these are two superficial layer. And the deeper layer is your medial head. And in the center is your central tendon. So these are the muscles. So let me clear all the drawings. Sorry. And just some of the nerves. Already I've talked about some of the nerves and little more about the nerves. So anteriorly, as you told, the two important nerves is here on the lateral side between the brachioradialis and the brachialis. This nerve is your radial nerve. On the medial side, we are having the median nerve. And in the cubital tunnel, this is your cubital tunnel. So in that, you'll be able to find out the ulnar nerve. So up to this, and if you have any quick questions, you can tell me. If you wish me to show anything, I can show you, and then I'll be going for the demonstration. So do anyone want me to demonstrate anything? No? Okay, fine. So let me stop sharing and let me share this screen. So is this screen is visible now?
Yes, sir.
My volunteer is ready, extending the elbow. And the probe what I'll be selecting here, remember, this probe is a curvilinear probe. So the curvilinear probe is not the right choice. So I'll be taking the linear probe. And I'm selecting the musculoskeletal MSK. I'm selecting elbow. So this is a high frequency probe, high frequency linear probe. And this is not just high frequency, very high frequency. Normally, we can take also this, the 412 megahertz probe also we can take, but we are having even that, with this probe, we'll be able to see the knobs even better. And that's why I'm selecting this 4 to 20 megahertz probe. So sorry, not this one. 4 to 20. So my aspect marker, let me put a lot of gel. Again, gel is very important. That day I was talking, if we are not having the good gel, we are not going to get good picture. So here, my aspect marker is on the lateral side. My aspect marker is on this side. This side is your radial side. So aspect marker is on the lateral side. That means on the screen. So this side is the lateral side, and this side, the right hand side of the screen, is your medial side. So what I told, over the crease, over the crease of the elbow, I'm just starting with the anterior elbow, and then we'll be going to the medial elbow, and then we'll be going to the lateral elbow, and then at the end, I'll be going to the posterior. So over the screen, I'm just holding it. I'm going above and below, and this is the home page. You know what I was telling you that time, that let me freeze it here. Let me freeze it here. So what I can see here, that look at not this one. So this was your this was your this side is radial side. This muscle is your brachialis muscle. So this is your capitulum. The lateral side is your capitulum, and this is your trochlea. Trochlea is a little bit depressed, what I was telling you. So this, whenever it is seeing this two hyperechoic line, and in between the black line, so you just understand this is my home page. And there is some, the whole is your brachialis muscle. Whole is your brachialis muscle. And there is some septa, fibers connected to septa is there. This muscle is your little bit of your what? Lateral side. Which muscle? Brachial. And this side, little bit of muscles, what you can see here is your pronator teres. So this is the home page. As soon as you'll be getting it, you stop there. And then what important here on the top of this brachialis muscles, we are going to see the BAM, B-A-M. So this is your long head and short head of the biceps. So lateral side is your long head, this side is your short head. And then we are having the artery, brachial artery, and then we are having the median nerve here. So immediately, whenever you are going to see this, you are going to see these structures. And also you can see here is your radial nerve here between the brachioradialis and the brachialis. So this structure is very, very important whenever you are scanning the elbow. Try to find out this hypoechoic line in between the two hyperechoic line. This side is your radiocapitulum joint, this side is your the trochlea. So now again, I'm unfreezing, and again, I'm just over the crease of this elbow, just go little above and down, and you'll be able to see it. So this is, you can see, very nice pulsation of the brachial artery, and on the medial side of that, you can see the median nerve. So let me first follow the median nerve, then you'll be going to the other side. So now, if at this point, I'm following the median nerve, you can see this median nerve, very nicely seen. I'm taking it in the center. So this is a quite big, thick nerve, and I'm following it. I'm following it. And see, look what is happening to the, this is your median nerve, and see what is happening to the brachial artery also. Brachial artery also will be dividing into the radial and the ulnar artery. So exactly middle of the screen. So this is your median nerve, honeycomb-like appearance, very nicely seen, honeycomb-like appearance. I'm taking down. Now where it will be coming? It will be coming between the two head of the pronator teres. So this is your median nerve. Follow it. So it is coming between the two head of the pronator teres. This coming down, and you have seen. You can see here the brachial artery has divided. This is your ulnar. This is the radial branch. So now median nerve is going along with the ulnar nerve, coming down deep. Median nerve, follow it. This was your nerve between the two head of the pronator teres, and then I'm coming down. See, this is the radial artery going on this side. The ulnar, sorry, this is the ulnar artery going to this side, and the median nerve is here. So now median nerve will be entering between the two head of the flexor digitorum superficialis. So now it is coming here. We are between the, now it is coming outside the two head of the flexor digitorum, and now it is coming. This is your flexor digitorum superficialis. This is your flexor digitorum profundus. So now the median nerve is coming between this flexor digitorum superficialis and the flexor digitorum profundus. Here is your median. So now rest still here. Here I can follow. Here, 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 and now it is entering into the carpal tunnel. So this part will be demonstrating on the next class. So now this was your median nerve. Again, just quickly recapitulating. This was your medial nerve. coming between the two head of the front arteries. Here is your radial artery getting divided, brachial artery getting divided into radial and ulnar. So radial and ulnar. So median nerve is accompanying the ulnar first, coming down deeper. Now it is entering into the two head of the flexor digitum superficialis. Ulnar artery going away, and later on the ulnar artery, if you are following it, you see this is the ulnar nerve. So when I'm coming down, the ulnar artery and ulnar nerve becomes together. So here this ulnar nerve and ulnar artery will be accompanying till into the Goyen's canal. And here is our medial nerve, which is coming between the flexor digitum superficialis and flexor digitum profundus. And okay, so this is your the flexor pollicis longus. Okay, sorry. So it will be coming in between the this side will be coming the flexor pollicis longus also. So median nerve is here. Okay, stop. Here was a median nerve. Here was a median nerve. So now let us see in the long axis. So this was your median nerve. Let me put it in the middle of the screen. And now my left-handed side is proximal side. Left-hand side is proximal side. Look at these nerves. I'm seeing this nerve now in the long axis. So that is the long axis of the nerve. You can see now it is dipping down between the two head of the pronate arteries. This is the median nerve. This is the median nerve. Now it has come between the flexor digitum superficialis and profundus. So this is your median nerve. Very nice. So it is a healthy volunteers. So hyperequilibrium structure. This is your median nerve in the long axis. Now another very important structure here in the anterior elbow is your okay, this was our home page. So another very important structure here is the long head of the biceps, distal end of the biceps. And some people say it is very difficult to say, but just if you're following some rule, it is not at all difficult. So if you are remembering our first class, what we told that to see a structure nicely in an ultrasound, what you need to understand that ultrasound beam should be coming back, reflecting back to our probe, to our transducer. Then we'll be able to see this structure as an hyperechoic structure. And if the ultrasound beam is not reflecting back to the transducer, that structure will be looking as an anechoic, black. So now what happens here? Here the long head of the brachius, the distal end of the brachius, it cuts down, and then getting attached to the radius. So because it is coming down, because it is dipping down, so it is not horizontal to the probe. So it is reflecting back, and that's why it is not visible nicely. So now there are several ways to see. I'll be showing you our own technique, and this will be able to see it very nicely. So look at this elbow first. So this brachial tendon, this long head of the distal brachius is very superficial. Even you can hook it, But the problem is, why can't we see? Even though it is so superficial structures, distal end of the brachius, why we can't see? Because it is dipping down and getting attached to the radius. So here, what we'll do, we'll be flexing it, and we'll be putting some weight. I'm giving this weight, and I'll be just, what I'm doing here by putting some weight here, I am, making this tendon tight, and it now becomes, with this angulation, it will be tight, horizontal. And another maneuver, what you have to do is if I'm putting these things, this part is dipping down. So this part is dipping down. So what I'll be putting a lot of gel, and I'll try to make this horizontal by heel to maneuver. You can remember the heel to maneuver? Heel to maneuver means I'll be putting one side, dip, pressing, another side I'll be lifting up with gel. So this is how we'll be able to make our probe transducer parallel to the distal end of the brachial, the biceps, and we'll be able to see it very nicely. It is very superficial. Huh? I'm putting a lot of gel there, and I'm putting this, putting this weight, little bit of, around 300 or 500 gram, give to this and ask the patient to flex a little bit, and then you try to find it out. So again, first is your short axis. What I'm doing, see, with this, what was your, this was your biceps. Why it is looking black? One part is black, one part is little bit of white, because again, same anisotropy. You see, that black will be looking white if I'm tilting the probe. You see, I'm tilting the probe, and now the black part is becoming white. So everything is, the anisotropy. If you're tilting it, sometimes it becomes black, sometimes it becomes hyperechoic, sometimes becomes anechoic. Now it is anechoic. I can follow it is anechoic structure distally, and it is getting to the radius. So now, what I'll be doing it, I'll be able to see it in the long axis, and I'm just putting the probe over here. I'm just putting the probe up there. You see, this most superficial structure, tubular structure, this is your biceps, distal end of the biceps. I am coming down, coming down, coming down. And now at this point, because it is dipping down here, it is difficult to see. So what I'll do the heel to maneuver. Sorry, let me do it so that you can see the probe nicely. So at this point, I'll be doing the heel to maneuver. What is heel to maneuver? Distal end, I am pressing down. Distal end, I am pressing down. And I am lifting the other side. Okay, so you can see very nicely, it is getting attached there. Let me feed it so that. Okay, so these are the distal biceps, because I'm getting attached to this tubercle in the radius. So because it is getting, the dipping down, we are unable to see. So what tricks we have done? Number one, we have made it flex, and I have made the tendon tight by putting some weight on the hand. So ask the patient to hold some weight, around 500 or 1 kilo weight on his hand, and try to make the elbow little flex. So now the tendon will be little more horizontal. And then along with that, you just put the heel to maneuver, distal end you press, and the proximal end put a lot of gel, and you just can see that way. So what is the advantage of that? Advantage is that even at this point where it is getting attached there, you can come and you can give the injection there. And another trick you have to remember, this is a tubercle where the distal end of the biceps is getting attached. It is the most medial side. And that is the reason why, again, I'm showing you. So this was your what? Capitulum. This was your radial head. So this was your head of the radius. So if I'm coming here, so I cannot see it. See, this is why? Because I can see the radial, the radius very nicely. If I'm seeing the radius very nicely, I will not be able to see the tendon, because tendon is little more towards medial side. So if at this point, if at this point, if I am going medially, and if I am, you see now the tendon is very nicely seen. And if I'm doing the heel to maneuver, you can see the whole tendon is getting attached here. And when you'll be seeing the tendon nicely, the radial, radius, you will not be able to. You can see the tendon is getting attached there over the radius, over the tubercle. You can see the whole tendon nicely getting attached there. But what I was trying to tell you, so now at this point, at this point, when you are able to see it nicely, so that time, this cortex of the radius is not nicely seen. Why? Because this tubercle, where it is getting biceps, is getting attached to the medial part. That's why you will not be able to see it nicely. So now there are different other ways to see. the distal biceps tendon. So one of that is if we are looking through your brachial artery. Other day I was telling that when you are, this is a brachial artery, when you are seeing something, we are telling that some acoustic window. So this is your acoustic window. See how I am holding the probe. I am tilting the probe like this. I am able to see the brachial artery nicely. And now at this point, you can see this is your distal bicep tendon getting attached. So this is another way to see. So this was your tendon getting attached. Here I am able to see it also better. Why? Because I was seeing through the brachial artery. So anything you see through the brachial artery through other vessels. So there is, you see this posterior acoustic enhancement. You see this is the hyperechoic area, posterior acoustic enhancement, if you can remember. So now this was your tendon getting attached here. And here the problem is, if you wish to do some interventions, if you are coming here or here, the problem is you cannot do any interventions here because here there is you are going to puncture the brachial artery. But the technique what I have shown you, that you are putting some weight there and asking the patient to flex the elbow, put some weight there, make the distal end of the biceps almost horizontal to the skin, and then you do a heel to maneuver and you'll be able to see the distal end of the biceps very nicely. So distal end of the biceps tendon is one of the very difficult part to examine in the elbow. But the trick what I have shown you, I am sure that this will be making your things very easy. So just ask the patient to flex, put some weight on your the hand. I have the gel bottle. I have asked him to hold and make a little flex, and then it becomes horizontal, almost horizontal, and with the heel to maneuver you can see. And now there are some other ways too. One of them is known as the cobra position. No, so cobra position. So the hand is like that, the cobra, like a snake, And here, see, if I am doing here, this side is your radius and this side is your ulna. So I'll be first holding that probe there, and then I'll be gradually turning this, making these pronations, maximum pronation. So what will happen if I'm pronating it? Then where is it is getting attached? It is getting attached anteriorly, anterior medial part of the radius. Now, if I'm doing it, then what will happen? This will come to the posterior part. Distal part will be coming in the posterior part, and you'll be able to see the insertion point nicely. So now you see here again. So what I'm doing here, let me put again gel. So this was your ulna and this was your radius. So at this point, what shall I do? I shall ask you see now this is what is coming is this hyperechoic structure. What is coming out is your distal end of the biceps. So again, let me put a lot of gel there, otherwise you'll not be able to see it nicely. So the most superficial is your ulna, just skin is your ulna, and the little dip. This was your radius. So now I'll be searching here, and I'll be asking the patient volunteer to do the cobra position. So now this is the distal end of the biceps. So this is another. So this is in the cobra position, so you can be able to see it. So these are there are other views also, other ways you can see. There are a lot of other ways, but just remember these two. For the injection purpose, you can use this one, cobra position, or also what I shown you, that is our own technique to see the distal biceps tendon. So that way also you can go for the injection in the tendons if the patient is having the distal biceps tendinopathy. That is not uncommon, not very common, but again, not uncommon. So this was about the distal bicep tendon. Let me wipe it out. And then another things in the anterior elbow is left. I have shown you the median now, and now I have to show you the radial now again. So radial now, again come to the home page. I'll take it clear. So if you can remember that the radial now is here between the two facial. This was your brachioradialis, this was your brachialis, and in this facial plane is your radial nerve. So radial nerve at this area, it gets, you see, if I'm following the radial nerve, you see, this was getting divided here at the elbow. Before that, it was only one. You know, if I'm going above, now the radial nerve is one. Here, a little deeper. Here it is only one. Only one. And now it is getting divided into two. And now it is coming in the facial plane. So you can see here it is now two. And now if I'm coming down, some vessels also will be coming now. Some vessels will be coming here. This is on, this is on. Some vessel is there and some vessel is there. Basically, you will be able to see the 4 black dots. So initially it will be only 2 by black dots and nerve, and the vessels will be coming later. So now the another vessel is coming here. Pulsating vessels here. This was another vessel. So this is the distal, this is the deep branch, this is the superficial branch. Deep branch, superficial branch. If I'm going above, vessels are not there, and this deep and superficial branch is getting united to form the one nerve. So at this point, it is getting a little deeper. This is one nerve. If I'm now coming down, so now it has become 2 nerves, and now this is 2 nerves. Vessels is still not there, and if I'm coming down, so now the vessel comes appearing. So now the 2 nerves you can see. This is one nerve, this is another nerve, this is one vessel, this is another vessel. So now, first let me follow the superficial and let me reduce the depth so that I can understand it nicely. So now just remember the superficial branch. So where it is now? It is the brachioradialis. So this muscle is brachioradialis, this muscle was brachialis. So you just follow, come below the brachioradialis. See, this was the superficial branch. This was your superficial branch. You follow this branch. I am taking it in the middle part. Just follow that nerve. Follow that nerve. I'm keeping it in the center. Now it is coming above the supinator. Just follow it. Follow it. Follow it. So now it is coming over the radius. So now this artery is your radial artery. So now it is coming here. This is your superficial branch. So now if I'm going to more distally, so it will be coming just lateral. So I'll be showing you that this was your nerve. This was your nerve. Just above the superficial nerve. So again, let me just a little bit of depth. 2.2%. So this was your brachialis, brachioradialis. In the center, follow the above nerve. This is deeper branch. This is going down. This is superficial branch. This is superficial branch. Deep branch is here. Deep branch, this is supinator 2 head, superficial and the deep head of supinator. So the deep branch is turning on this side and it will be going to the posterior, the dorsal compartment. So I am following this now. This one, center. Okay, now it is going on this side. So, and it is in between this is your radial artery, this is your radius. So this is your superficial branch. And if I'm following the deep branch, so let me decrease the depth a little bit. Deep branch will be first coming into the radial tunnel. So radial tunnel is where? Radial tunnel is situated just over the radiocapitular joint. So the base is formed by the capsule. On the lateral side, we are having the brachioradialis, and it will be coming then into between the 2 head of the supinator. So this was your deep branch. So follow the deep branch. Now it is coming between the 2 head of the supinator, superficial and the deep. Now here the nerve is little flatter. This one. Follow that nerve. It is coming here. Coming here. Here is the nerve. Here is the nerve. So now that is now called as the posterior interosseous nerve. Let me put some gel over this dorsal part of the forearm. Let me start from here again. Home page. So this was the home page. So the two nerves, and later on blood vessels is appearing. Now the blood vessel is appearing. We just follow the nerve. So now it is between the two head of the supinator. So this is your nerve going from the medial to lateral side. So now this was the nerve. Now it is coming on the dorsal side. This was the nerve coming down, coming down, coming down. So now it comes below the extensor digitorum. It comes below the extensor digitorum. This muscle is extensor digitorum muscle. And now extensor indicis also. This is the extensor digitorum, and below that is the extensor indicis. So now if I'm going below, now it is accompanied by one blood vessel there. And if I'm going below, so this is in the fourth compartment. So the posterior interosseous nerve comes in the fourth compartment. We can see the pulses in there also. You can see the pulses in there. So that is the posterior interosseous nerve, terminal branch. So this muscle is the extensor indicis muscle. Above that is your extensor digitorum. Extensor digitorum is tendinous here. But extensor indicis is the last muscle which is supplied by the posterior interosseous nerve. Posterior interosseous nerve is, you can see the very nicely pulses in here. And just, you can see the nice pulses in there. And just hyperechoic structure just below, beside that is the terminal branch of the posterior interosseous nerve. So it supplies the last muscle supplied by the posterior interosseous nerve is your extensor indicis muscle. So this was your extensor indicis muscles coming below. This is your extensor digitorum. So if I'm coming here, so now you can see this, the third compartment, fourth compartment, the extensor indicis muscles is going there. We'll be discussing this in detail in the wrist class. Okay. So here again, let me follow. So here was deep branch. This was your deep branch. Deep branch, follow the deep branch here. This was deep branch coming in between this two head of the supinator, coming here, coming this side, coming here, scooping down here, this one, coming below. Now it is coming below the extensor digitorum muscle. Here is the nerve. This is the nerve. And now it is accompanied by one blood vessel. As I told you, the posterior interosseous nerve is to be now accompanied by, now it is called posterior interosseous nerve. And now it is accompanied by one blood vessel. So you can see the very nicely. So the blood vessel and nerve. This is nerve, and this is the two dot. This is nerve, and this is blood vessels. And the now two will be coming together. So this is your extensor digitorum. This is your extensor indicis and extensor pollicis longus. So now if I'm coming down, it is now dipping down. Sorry. Again has increased about. Okay. So here is the nerve and artery. Just see pulsations there. Now coming down deep. Now it is coming below the extensor indicis. So see here, this one coming down here, coming down here. Below the extensor indicis, as I told, last branch is your posterior interosseous nerve, is your extensor indicis muscle. You can see the nice pulses in there. Okay, so this is your anterior elbow. So I hope everybody has appreciated. If anybody wish to see anything again, I can show you. No? Nothing? Okay, so now I'll be showing you the medial elbow. So in the medial elbow, two important structure. One is your medial ligament complex, or also called the ulnar collateral ligament. 3 band of the ulnar collateral ligament. Let me reduce the depth a little bit. So here you just see, let me hold the probe here this way so that you all can appreciate it. So if I'm holding the probe towards the little finger, this one, this side, ulnar side, then I'm going to see the. So what is this? This is your medial epicondyle. So this has a slope, very big slope. And this is your, what is this? This is your sublime tubercle. If I'm holding it like this, sublime tubercle. Anteriorly, the same tubercle is known as the coronoid. But here, oh, anteriorly, I have forgot to sorry. I have forgot to show you the joint, the two important joint, radiocapitular joint and the ulnar. Sorry, I forgot to mention so that two joints. Let me show that, then I'm coming to the medial part. So this is your radiocapitular joint. Radiocapitular joint, normally you see the radial head is little bit of flat. So this is how you'll be able to understand this. And this part was what? This was your radial fossa. You can see this is your capitulum. This is a very nice articular cartilage. Above that, a little bit of fat pad and then the joint capsule. So if there is an effusion, this fat pad will be getting elevated. So this was your joint capsule. And this was your radial fossa. This is the radial head. And here was the annular ligament, which is coming, which is inserting there. So this was your radiocapitular joint. And if I'm coming medial side, gradually now it is coming. So this is your what? Ulnohumeral joint. So here again almost similar, but here you see this is not as flat as the radiocapitular joint. Here the coronoid process is sharp. So this is the coronoid process of the ulna, and this is your coronoid process. So when you are doing the flexion, this coronoid process will be coming here, and the same way it will be here. So what muscle is there? This muscle is your brachialis muscle. So brachialis muscle is getting attached. It is coming over the coronoid and it is getting attached over the ulna. And if I'm going laterally, this muscle is your pronator teres muscle. So this is your brachialis coming here and getting attached here. So this was left in the medial elbow. I'm sorry, anterior elbow. So now coming to the medial elbow. Medial elbow, I am holding the probe first over the. This is I'm palpating. So this is your medial epicondyle, and I'm putting the aspect marker towards this condyle, so that let me freeze it here. So what can I see here? This was your condyle, and this is the slope, and here is your coronoid process. When I am on the medial side, almost looks similar, but then it becomes sublime tubercle. So now again, so if I am tilting the distal end, I am putting it almost like this. Let me show you here. See, I am holding like this. I am holding the probe. Sorry. Holding the probe like this. So here I can see the anterior band of the ulnar collateral ligament very nicely. So this is your ulnar collateral ligament coming here. And if I am moving the distal end of the probe on this way, now I can see towards, because the tendons are coming like this. So if I am tilting my probe this side, now I can see the common flexor tendon very nicely. So this is your common flexor tendon. So as I told you, most superficial, the muscles and the most bulky muscle is their pronator teres. Pronator teres is one of them, and 4 other muscles across there: superficial layer, pronator teres, then flexor carpi radialis, the palmaris longa, flexor carpi ulnaris, and then little deeper is the ulnar hard head of the flexor digitorum superficialis. So this is your common extensor tendon. To see the common extensor tendon, what I am doing? I am tilting the distal end of the probe towards the thumb. So then I can see this common extensor tendon nicely. So if I'm thinking of doing the injections here, like the thing here, if I'm giving the injection here, so my needle should be coming here. Just just injections. Normally you puncture it to the fenestrations, then it gives better result. And here at this position, I cannot see the ligaments nicely. So for that, For that, what I'll do, I'll be tilting the probe here. So now I can see the ligaments very nicely. Okay, so what I was saying here, this was your anterior band of this ligament. So where it is coming? It is coming from the medial epicondyle till the sublime tuber. So this was the sublime tuber. So now what I was telling, the transverse band is difficult to see, but again, not that really difficult. I'll be showing you. So first what I'll do, I'll put my distal end of the probe over the sublime tubercle fixed, and then I'll be rotating. So I was holding the probe like this. So what I'll do, I'll be putting my distal end of the probe over the sublime tubercle nicely, and then I'll be rotating the proximal end of the probe toward, like, if you can remember, it's a triangle. So one end of the one is the anterior band, triangle is like this. This is your transverse band, it is like this, and another band was like this, like this. This is the very easy to see, that is your posterior band. So now, again, let me try, and please follow it nicely. So first you look at here. This is a little bit of uncomfortable here in this position. So what I'm doing, this part where my, the pointer is there, that is the sublime tubercle. So this part was the medial epicondyle. So now I'm putting my probe over this bone, and I'm just gradually rotating the proximal part. Sorry. So this was your sublime tubercle. My pointer is over the sublime tubercle, and now I'm rotating it, keeping that sublime tubercle part fixed. And now gradually what is happening? The condyle has gone, and now what bone will be coming there will be olecranon. Now this is your very nicely seen. Very nicely seen. This is your transverse band. People say that the transverse band is not visible, but yes, it is visible. So if you can remember if you can understand the anatomy, yes, it is nicely visible. This is your transverse band of the radial of the ulnar collateral ligament. So this is from sublime tubercle to this one. So you just hold the first, you see the anterior band, and then you gradually rotate, and you will be able to see this band there. So this was the transverse band. And now another very important is your cubital tunnel, and where I will be able to see the you have to put a lot of gel there because there is a depression there. Okay, so my aspect marker is towards your condyle. This is your olecranon. You can see this is the space gap. So now this floor is by the posterior band. See, whole this hyperechoic horizontal line is your posterior band. This is your ulnar nerve, and this superficial one is Osborn's ligament. So Osborn ligament is your flexor carpi ulnaris muscles. It is having the two head. So in this two head is having the aponeurosis, and that is known as the Osborn's ligament. So this is your connecting between your medial epicondyle and the olecranon process. This is your ulnar nerve, and this is your cubital tunnel. So now we should examine this in dynamic position. Means it should be flexing. I'm keeping it here, flexing and extending. And the ulnar nerve should be always there in the cubital tunnel. It should not be dislocating. If at this position, if this nerve is coming out, then that means either subluxation or dislocation. So in that position, you can do the flexion extension, and you can see whether it is subluxating or dislocating or not. So this was your Osborn's ligament, is very nicely seen. Osborn's ligament, hyperechoic line. And the floor, your posterior band of the ligament is also seen. So this was your medial elbow. And now the posterior elbow. So for the posterior elbow, so the crab position. Okay. So my volunteer is very cooperative. Many of you know him, know her. Okay. So what I'm doing, my aspect marker is towards the olecranon. This side is your aspect marker. That means left hand side of the screen is over the olecranon. So now what I can see here, this is your olecranon. This is your olecranon fossa. Here, this is your fat pad. And you can see that triceps. This is the muscular part. Above central part is your fibrous part, the tendinous part. Tendon part is the central tendon is there. This part is your deep part. I told you, or medial head. Medial head is the deeper head. If I'm going laterally, then it is the lateral head. This is lateral head. This is the central tendon, and the below muscle is your medial head. And if you are going more medially, and then, sorry, this is your medial head. This is your long head. This is medial side. This is lateral side. So this is your lateral head, and deep one, below one, this is the medial head. Medial head is deep, lateral is lateral, long head is medial. And if you wish to go for the injection, so here in this direction, you should come and give the injection here into the gap. You can see the olecranon, tip of that. And sometimes there is a bursa, that is your bursa is here. If you wish to give olecranon bursa injections. So now I'll be showing you also in the short axis. In the short axis, see, the deeper one side is your medial head, another side is lateral head. Okay, let me see here. So this part is your hole from here to here is your medial head. This is your lateral head, and this is your long head. So medial is whole below, and lateral head and long head. Long head is medial. So this is in the short axis. And bursa and injection I have shown you. So now you tell anything else you wish to see again in the elbow, anterior, lateral. Oh no, I have not seen the lateral. Sorry. I thought I've completed the lateral. So lateral, just again put your. Let me put it here. So lateral, you have to put one part of your over the lateral. So what I am lateral epicondyle. So what I am doing, I'm holding the probe like this, and the aspect marker is towards on the lateral epicondyle. So this is the lateral epicondyle. So here, what you can see here. So this is the lateral epicondyle. This is the slope, and this is the radius. So this is the common extensor tendon. And if you can remember, the most bulky the muscle is your extensor carpi radialis brevis. Extensor carpi radialis brevis goes little above us, and after that, the four other common extensor tendons. Three other common extensor tendons. Total common extensor tendon has the four muscles. So starting from the flexor carpi radialis brevis, then your extensor digitorum. These are all superficial muscles. Then extensor digiti minimi, and last one is your extensor carpi ulnaris. These are the four muscles, most bulky, and the most, the radial side muscle is your extensor carpi, the radialis, extensor radialis brevis. So this is one, your extensor tendons, and this below part, you can see very nicely, this is the radial collateral ligament. And here is your annular ligament. Annular ligament also I'll be showing you in the other axis as well. It intermingles with this. So the lateral ligamental complex, one is this part. So upper part is your tendinous part, lower part, this part which is coming here below the tendon is your ligamental part. And it get intermingles with the annular ligament. So let me show you again. So this is your extensor carpi radialis brevis tendon, the most superficial one, and it is going little above as well. And now this is your tendon. Sorry, this is your ligament, and this is your annular ligament. Now, annular ligament, I'll be showing you in the short exercise. So this is your radial head. So this is your annular ligament. And if I'm holding like this annular ligament and the radial is basically interligament. Now, at this position, I'll be keeping the distal part of this hand is the pronated, the distal part or left hand side aspect marker, not distal, sorry, proximal part aspect marker I'm fixing. And what I'm doing, I'm rotating this was the radius. So now I'm distal part, I'm rotating towards the ulna. See, now the radius is vanishing. Radius is vanishing. So now another bone will come. That will be your ulna. So now ulna has come. And now here I'll be searching for the here. So this is your lateral ulnar collateral ligament. So the medial ulnar collateral ligament or only ulnar collateral ligament, and this is your lateral ulnar ligament or lateral ulnar collateral ligament or just lateral ulnar ligament. So in the lateral ligament complex, so there are 3 ligaments. So one of them is the lateral ulnar ligament. So this is your lateral. And if I used to go, the most common is your tennis elbow. Though tennis elbow is a misnomer, it's basically tendinosis of the. So tendinosis of the. So this is the tendon, common extensor tendon. So if you used to go for the tennis elbow injection, then your needle should be coming like that, and it should be puncturing multiple times so that the vascularity will be increasing, and that is the best way to treat. And you can give the PRP. PRP is having the better evidence than the steroid. Steroid never give you the substance of the tendons. So you have to give either below or superficial to the tendon. Okay. Any questions? Lateral elbow, medial elbow, anterior. Anterior, there are a lot of things. And the posterior elbow. Any questions? No question. Everybody is silent.
Sir, can you show
Okay.
the elbow again?
Which elbow?
The lateral.
Lateral elbow. Okay. So lateral elbow, what are the things? The lateral ligament complex and the common extensor tendon. So lateral ligament complex has the 3 component. One component is the radial collateral ligament. One component is your annular ligament. Another component is your lateral ulnar ligament. So lateral ulnar ligament and lateral collateral ligament is originating from the tip of the lateral epicondyle. So if I am holding the probe here, so the upper part is the common extensor tendon. So this is your common extensor tendon. And the lower part here, this hyperechoic area is basically intermingling with the lateral collateral ligament with the annular ligament. So this hyperechoic structures above the joint. So this is this joint, this ligament comes from here. Another thing you remember, tendon normally becomes more of straight line. The fibrillar pattern is not lax, not sagging down, but ligament normally sags down when it is relaxed. When you are tensing it, then it is stressed, but otherwise ligament sags down. You always remember it. So any ligament sort of, whenever you will be seeing it, it will not be as straight fibrillar like that of the tendon. And tendon, one side will be attached to the bone, another side will be attached to the converted into the muscle, but ligament will be from bone to bone is your ligament. So this is your ligament and getting attached with the intermingled with the annular ligament. So here was annular ligament. If I'm coming here, this was your annular ligament. This was your annular ligament. See, I'm holding the probe. So the radial head above that is your annular ligament, and this was your lateral radial collateral ligament. And then what I was telling you, that you fix the proximal end of the probe over the condyle, lateral condyle, and you rotate the distal part,
And so first it was the radial head. The radial head will be gradually disappearing, and another new bone will come. Now the ulna has come, and now bone tilt a little bit, and now you can see this is your lateral ulnar ligament. So this ligament is your lateral ulnar ligament.
Okay, so this was lateral ligament complex. And another thing is very simple. That is your common extensor tendon.
So the superficial one, the upper half, upper part, this is your common extensor tendon.
Is it okay?
Yes, sir. Thank you.
Okay. If anybody wish to see any structure again, I can show it again. Otherwise, Milton
Or
is
can you see bicipital aponeurosis?
bicep lacertus fibrosus.
Yes, lacertus fibrosis.
Okay. Lacertus fibrosus, I forgot to show you. So lacertus fibrosus was what? In the anatomy slide, I have shown you that the distal end of the bicipital, above that, there is a bicipital aponeurosis. And bicipital aponeurosis is a fibrous band which covers the median nerve and the brachial artery. So what do you have to do?
Again, the same home page. So same home page. So here, what you can see here is your
Sir, ultrasound image is not seen.
Oh, sorry. I forgot to share. Sorry, sir. Okay. So bicipital aponeurosis, another name is your lacertus fibrosis.
so again home page. This was the home page, and here what you can see here. This side is your medial lateral side, radial side. This side is your the right side of the screen is your. So now at this position, this is your which is fibrous bands going above the median nerve and the brachial artery. This is your the bicipital aponeurosis or lacertus fibrosis.
Thank you, sir.
Okay, thank you very much. And oh, Milton, I have to make you co-host. Sorry. Now, Milton, you are co-host now, and you can share your slide. And meanwhile, if anybody has any question, you can put it on the chat box and we can answer it.
Sir, can you hear me?
Yes, we can hear
Hello.
you, Milton.
Okay. Thank you, sir. After a nice anatomy and ultrasonogram demonstration, now we are looking forward to the elbow pathology. Just a minute. Okay. So, before starting our main class, we will discuss these topics in our class, like the joint abnormalities, tendon and muscle abnormalities, like the bicep, distal biceps, brachialis insertions areas, triceps insertions areas, common flexor and extensor tendons, and some ligaments like medial collateral ligament complex and the lateral collateral ligament, and some peripheral nerve abnormalities like the ulnar nerve, median nerve, radial nerves, and others. And two common bursa there is the olecranon bursa and cubital bursa also. And there's some myofascial pain symptoms in the elbow area, like the anconia symptoms, supinator symptoms, brachioradialis, and also the anterior interosseous symptoms. Also, there are some symptoms is there. So now I am going forward. So though elbow arthritis is not so common, but it's not the less common also, because many of the time we saw that especially the osteoarthritis and also the some form of the inflammatory arthritis like the rheumatological problem, just like rheumatoid arthritis, or sometimes some peripheral spondyloarthropathy and psoriatic arthritis. Also, we can see this arthritis of the elbow also. So, in case of these things, always find out arthritis as well as the some coexisting factor, like if there is any coexisting factor like the bursitis or tendinitis. So ultrasonography gives a very important role to diagnose these things. So some symptoms we can find out the arthritis like the swelling, stiffness, pain also, and the some clicking sound, and the some rotational or forceful movement, it causes the pain also. So already I have given you the topics, the like the rheumatoid arthritis and osteoarthritis, like the gout and psoriatic arthritis and juvenile arthritis. So it may actually affected the elbow arthritis most commonly. So how can we differentiate it from inflammatory arthritis to the degenerative arthritis? So usually in case of the young patients, many of the time they are this pain become more in the resting condition, and also it decrease with the activity, like when I'm in sleeping, or after getting from the sleep, or when I am taking for the long period of rest. After that, the pain is increasing, and morning stiffness just near 1 hour or more than. But in case of the degenerative changes, like the degenerative arthritis, it is only in the in case of the after 45 to 50, the older age, and also the pain that usually decrease in the rest condition, because it is the mechanical, or when actually people are working, the more tension or more force over the joint, so it causes the pain. So patient, when actually they have take the rest, so that time actually pain is decrease. So when they are actually work, so that time the pain is increased in case of the degenerative arthritis, and it's less than 30 minutes. Okay. So usually if it is the inflammatory condition like the rheumatoid arthritis, psoriatic arthritis, or gout or something. So that times actually we have planning for the steroid injection, 1 ml of local and 1 ml of steroid. That is enough for this kind of arthritis, and because it is a very small joint. So in case of the degeneration, so that time we can give the interarticular PRP, like 1 or 2 ml of the PRP in the interarticular. So very common topics, we know that is called the tennis elbow, but now at time actually we're not talking, we're not actually look at like this the tennis elbow. It's a complex, and it's just called as like the lateral epicondylgia or epicondylitis. Why not epicondylitis? Because there are some author, they have researched a lot of over the lot of peoples, those have actually lateral elbow pain. The very minimum or few amount of actually inflammatory marker or inflammatory uh, just product. So many of the time the inflammatory marker are not so high, so only the degeneration, that is the markedly they have actually shown in their literature. So they have actually called these things more suggestive of lateral epicondylgia rather than epicondylitis or tennis elbow. So it is the condition that causes the pain in the lateral elbow of the lateral side of the elbow joint. Clinically, it is called the lateral epicondylgia or epicondylitis. So most of the time, actually, it's occur due to the repeated work. Why it is come as a tennis elbow? Because we shown that those people are actually playing the tennis. Among total player of the tennis player, around 50% are suffering this type of the problem. But in case of the total population, we can see it's near about 1 to 4.3% all over. But if we are actually in total of less than 5% of the tennis abuse diagnosis related to the actually playing the tennis. So people who are actually playing this tennis, so previously we have called like this the tennis elbow, but after that, when actually a mass research, people are not playing the tennis, but they have actually working some like this the screwing, sometimes they have actually working in the household, they have also these kinds of problem. So that time actually research, and they have found there is no a lot of inflammatory markers in there, so they have found some other than inflammation, so they have actually called the lateral epicondylgia. Now sir all have already shown these things. There is the four muscles in the lateral epicondyle. There is the extensor carpi radialis brevis, extensor digitorum communicans, and extensor carpi ulnaris, and extensor digitorum minimi. So among these four, most common and most affected muscles and tendons, that is the extensor carpi radialis brevis, not longus, because longus actually inserted above the epicondyle. So at the epicondyle, these four muscles are inserted, and among them, most affected tendon are the extensor carpi radialis brevis. Okay. So if we are looking for the pathology, like so pathanatomy, there's the some micro trauma or micro tear on the origin of the common extensor carpi radialis brevis, and also some there is a small tear or a small micro trauma that is also in the extensor carpi radialis, small count of the longus also, but it is not the part of the epicondylgia, and extensor carpi ulnaris. Okay. So in case of the pathophysiology, we can see there is the micro trauma, and also there is the angiofibroblast hyperplasia, and some there is the deorganized collagen. These three things are seen over the when we actually see the microscopically what actually happened in this area. So many of the time there is radial tunnel symptoms may present around 5% this type of condition. Okay. So if we are see the some pictures of the ultrasound, we can see very easily in the slope. Share you. Okay. In the slope, above the slope, this is the tendinous part, but the lower of the slope part, that is only for the lateral collateral ligament. So this is the muscles, it comes and it's just converted into the tendon. Here we can see the small partial tear. Okay. Always when you see the some hypoechoic area, always heel to maneuver must be given and must be doing, because you need to just either it is a false or it is the actual there is a tear or not. So because we know that already, we saw many of the time, because if the probe is not is perpendicular, so that time you cannot see the actual structure, because the sound is not come after reflecting, the sound is not come towards the probe, so you cannot see these things, the actual position or actual pathology. If it is not pathological, so it is so fine, but it is pathological, then you have to ensure either it is pathological or it is the anisotrope. So heel to maneuver and toggling is very important for ultrasound. And another one things, if there is any tear or any tendon degeneration or tendinosis, always give the Doppler. If these muscles or tendon have taken the color after giving the Doppler, so that's shown that there is the neovascularization. So inflammatory part is there. So if you're thinking either it is the degenerative part or it is the inflammatory part, because your treatment planning is the difference from degeneration to the inflammation. So here I have actually share how can we differentiate the number one, that is the almost the normal anatomical structure. The second one, there is the high Doppler taking this structure, so it is the uh, inflammatory site. So third one, there is the no Doppler, just you can see there is the degeneration, the increase the um, thickness of the tendon. And the fourth one, there is a degeneration and also small amount of the color have taken by the tendon. So this is called the both inflammation as well as some degeneration there. So here we can see the full thickness tear of the common extensor tendon. And here we can see the calcification of the lateral epicondylitis, and also you can search it in the X-ray. And why you can we are called it the calcification, because sound beam actually cannot cross this area. So below this hyperechoic area, that is almost anechoic, or you cannot see the slope of the whole of the epicondyle. So, and in case of the X-ray, we can see the whitish collection or whitish something in the just correspond with the ultrasound. So this is the calcification of the lateral epicondylitis. So clinical examination, the local tenderness is very important, but many of the time, if there is the lateral collateral ligament, if there is any injury or any tensed, if even the annular ligament is any injury or any changes, so that time also the local tenderness may be present. So you have to actually correlate with the clinical examination and also the ultrasound. If needed, you have to do more things also. And another one things, if there is the stressing, that time you can see the ligament. And if there is any problem in the ligament, you can identify and you can just compare with the tendon also. So special test, that is the Cons test, Mills test, and Marlin's test. So you can see it from the net, or many videos there. So I'm not sharing these things so much. So treatment, actually the rest, the local cold or hot applications, NSAIDs. Sometimes we are, if there is degeneration, so that time actually we have actually mostly we like the PRP. And the needle fenestration is very important, because there is the degeneration, the actual the fiber is degenerate. So if we are just needling or fenestrating this tendon, so that time actually neovascularization, neoangiogenesis, and some if you are giving the PRP, so this total mechanism actually mainly improve the uh, degenerative tendons towards the normal. Okay, if you are planning for steroid, just you can below or above the tendon, not within the substance of the tendon. That is very important things. You can give the physiotherapy and sometimes the spleen also. Okay, so how the you are taking care by the needles. So there is, you can see how can we actually see these things. And needle is come from the forearm to the wrist part. Okay, forearm to the elbow. So here we can see the needle just towards the common extensor tendon area. Okay, there is some literature, they have shown that in just when it is the injury part or before giving any kind of medication, even needle fenestration, the tendon is more thickening. After few months after taking off needle fenestration with PRP, it's going down towards the normal, and it's almost the normal after the 6 month. And another, they have actually uh, taking two these things. One is the vast at resting condition, another is the vast during the active position. So before giving the PRP injection, there's been you have the pathology, but you are not taking care of the any medication like the PRP. So that time the VAS is the 4 or active. During activity, there is the 7. And patient-related tennis elbow evaluation, that is score. There is the course score. It's 0 to 100. So it is for 53, and the pain subscale of the it is under the 50 and 0 to 50. So one is the subscale, that is the non-functional condition. There is the functional subscale during the functional condition. So before the PRP injection, everything is the so high. After giving of PRP, after 4 weeks from the days of the first PRP, it's come down, and remarkable come down. And after 3 months, it's near about. During the rest condition, there is no pain. During the forceful or activity position, that is, it's was near the 2. And patient related tennis elbow evaluation, it is near about the 6.5. And the subscale in the non-functional condition, that is the 4. And when it is functional, it is around 2.5. So every parameters just come down towards the normal before it's after doing the PRP, but before the PRP it's so high. Now I'm talking about the golfer's elbow or medial epicondylgia or condylitis. So this is actually affected the medial part, and there is the 5 muscles in this area, and most commonly there's the 2 muscle are affected. One is the pronator teres muscles, and another is the flexor carpi radialis muscle. So 2 muscle are mostly affected in case of the golfer's elbow or medial epicondylitis. Okay. Actually, those people actually playing the golf or the racket or even the weight training. So these people actually affected this type of the problem. And mostly degeneration, but sometimes there is some secondary inflammation is there. So already sir sir has already talked about these things, the superficial group and deep group. I'm not talking so much about it, but superficial muscles, there is the pronator teres and the flexor carpi radialis. These 2 muscles are the most commonly affected in case of the common flexor tendon or tendinitis. Okay, so here actually shown how actually muscles is affected. So sir already shown there how your ultrasound probe can show the common flexor muscles. So it's the distal ultrasound part is towards the thumb. Okay, so from thumb to the little finger, it's like this: the pronator teres muscles, then the flexor carpi radialis, then palmaris longus, and flexor carpi ulnaris. So here it is the distribute. So the same, almost there is the microtrauma. If there is any microtrauma within the sorry, here is some problem. Okay. So the clinical examination, so it is the localized pain, and also the POC test, and sometimes the golfer elbow test. So we can actually identify in both clinically, and also we can do the ultrasound. If there is any changes in the medial common flexure tendon, then we can just call it like the medial epicondylitis. Okay, so here already we have just seen it, the upper one or superficial part, that is the common flexure tendon. In the below part, that is the medial collateral ligament, especially the anterior part or anterior. There is the three bands, so anterior band we can see here the greenish area. So here we can see the third picture. There is the small tear, and also there is the degeneration, thickening of the tendon, and also the loss of the fibrillar pattern of the normal from the normal fibrillar pattern is lost. So here is also we can see there is some degeneration in the medial epicondyle. So injection here, you can give this injection by this maneuver. So the same things you can give the PRP. If there is any inflammation, you can give the steroid also. So some ligament pathology we can already we have shown there is the medial and the lateral two complexes of the ligament. And both ligament actually maintains the force, because when it is the forceful, so this forceful, any forceful pressure over the elbow, it causes the elbow ligament any problem. Like if there is the lateral force comes from the lateral side, and it's any type of the like outstretching of the hand or like this, so that time actually medial collateral ligament is affected. So trauma is the very important part if there is any ligamentous problem. And we know already we know that ligament is the connection between the two bones. So these bones, if are in the same plane, so that times actually ligament is not so very well. If there is any injury or anything, so we need to just stressing these things. So both when the actually stressing these things, we can see the ligament, the total length, it is structure, like the thickening, like the pattern, and if there is any abnormalities, we can see very easily. So in the lateral epicondyle ligamentous, so lateral collateral ligament complex, there is the three ligaments, sometimes maybe added another one. So one ligament, the first ligament is the radial collateral ligament, second is the lateral ulnar collateral ligament, third is the annular ligament, and fourth is the accessory lateral collateral ligament. So this fourth ligament is very important, but first two ligament are usually affected the injury and usually shown the pathology commonly. So first we can see it is near the almost the perpendicular of the surface. We can see this part, that is the radial collateral ligament, and above the radius, head of the radius, that is the annular ligament, and the distal part needs to the downwards to the ulna, just when actually radial bones is vanish and come to the ulna. So that times you can see the lateral ulnar collateral ligament. This is the lateral ulnar collateral ligament. So this complex, especially the radial collateral ligament and the lateral ulnar collateral ligament, are most affected by the any injury or any stressing position. Okay. Now the medial ligamentous complex. Here is actually one ligament, but there is the three parts. The one ligament, that is the medial collateral ligament. So there is the three parts. Number one is the anterior oblique ligament, then is the posterior oblique, and another is the transverse ligament. So nicely we shown the transverse ligament by this sir, because this transverse ligament is not shown usually very nice actually I think tips by the sir. How can you actually find out the transverse ligament? So the first anterior band, it is from the this part to the sublimbus tubercle, and another is the sublimbus to the posterior part, that is the transverse ligament, and another is the medial epicondyle to the downwards, that is the posterior ligament. So these three ligaments, so usually most affected the anterior band. Okay, and it also actually maintain the stability of the elbow. So here we can see the upper part, that is the common flexure part, and the lower part, that is the ulnar collateral ligament, especially the anterior band. Okay, the pathology. So here we can see it is the thickening. If we see the distal part, there is not so much thickening in the proximal part near the sloping area. So this is the actually thickening. So this is actually there is the degeneration is there, and there is the anechoic area. So some tear, some small tear or partial tear is there, and there is the long almost the whole substance. So near the complete tear or near complete tear. Now we are looking for the nerve entrapment. So already we have know that there is the three main nerve in the elbow. One is the median nerve, another is the ulnar nerve, and another is the radial nerve. So most common, so here is very important part. Okay, when actually cross the median nerve from arm to the forearm, that is the transitional part. So here is this transitional part. It's this structure is maintained is actual site or actual area by the help of the one very important thing, that is called the lacertus fibrosus, because it's just come under the lacertus fibrosus, and lacertus fibrosus is actually part of the biceps distal biceps tendon. It is just come down to the medial side. So it is a transitional part, so it should be the maintained. And this nerve actually goes under the lacertus fibrosis. So if there is any thickening of lacertus fibrosis, so it causes the compression or pseudo compression over the median nerve, or if there is any pathology of the median nerve, because it is a very narrow space, so there is no huge space for the expansion, so that time actually causes the pain, any nerve dysfunction like the tingling sensation or any paresthesia, or if there is any kind of like the numbness, so that's actually causes the distal of the affected part. Okay, so these nerves actually come down, and after that it crosses the two heads of the ponator teres. So it also side for the affected or entrapment part. So the ponator teres have the two part, one is the superficial and is the deep. So when the median nerve comes superficially, after that it crosses the downwards and goes most deeply. So here actually there is the one muscles, this is called the pronator teres muscle, there is the two muscle fiber of pronator teres. One is the superficial and one is the deep. In between to this, the nerve is come down. So here is also maybe affected or sometimes entrapped here. After that, the superficial part, especially the anterior interosseous nerve, it arises from the median nerve and just goes to the pronator teres muscle and travel to the anterior aspect of the interosseous membrane of the forearm between the two muscles. One is the flexor pollicis longus and another is the flexor digitorum profundus. So here also in between the two muscles, so it may be sometimes entrapped also. So now, I have already said there is the pronator teres, there is the two head, and in between two head, the median nerve may be the compressed. So usually the volar side, it may be the pain, numbness, and sometimes tingling sensation is there. So either it is by the trauma or either it is by the any hematoma or any pronator teres muscle hypertrophy, even in the congenital abnormalities also. So there is the one muscles that is also, it's also arises from the median nerve, there is the anterior interosseous nerve. So if there is any actually compressed or any entrapment by the two muscle, flexor pollicis longus or flexor digitorum profundus, so it may be, it causes the tingling sensation, weakness, and affected the muscles, especially the thumb, index finger, and few in the middle finger. So these two finger is affected, and it not arises from only the wrist. So that time actually you have planning or you have actually searching the anterior interosseous symptoms. If this problem arises, but it's after the crease of the wrist, so it may be due to the median nerve entrapment at the carpal tunnel area. And this time special patient cannot like this sign, O sign, because this is mainly the motor supply. So this muscles is not so nerve supply is hampered, so cannot this sign, the O sign. Another very important things, always the proximal any pathology you should planning. Why? Because you know that this is the C6 distribution, this is the C7 distribution. So if there is any tingling sensation, any numbness, any weakness, so you have to actually search this also the neck, any neck pathology like the C6 radiculopathy or C7 radiculopathy. So you need to the Sparling test or you need to the Valsalva maneuver or like these things. So always you have to search and just correlate the clinical findings and also correlate the ultrasound, and also sometimes may need the MRI, because if there is any numbness or tingling in the thumb, not always due to the C6 radiculopathy, not always due to the anterior interosseous nerve pathology. Okay. So these symptoms may be due to the hematoma or masses, or sometimes the direct trauma in the direct trauma, because it is the superficial. Okay. Now the ulnar nerve, I am not so much about the anatomy, but one important things, when actually ulnar nerve cross the posterior side of the elbow and cross the posterior part of the medial epicondyle and towards the elbow, there's times actually ulnar nerve travels a channel. This is called the fibroosseous channel. So this channel, many of the time, actually entrapped and causing the ulnar nerve entrapment. Okay, so here one muscles, this is the flexor carpi ulnaris. These muscles have the two head. One is the superficial and another is the deep. So in between to this, just nerve come. So there is another ligament. This is called the osmos ligaments. These few things actually causes the soft tissue entrapment. That is the ulnar nerve entrapment, and distal this entrapment. Actually, you can find out the symptoms. So here, the cubital tunnel symptoms of like this or ulnar nerve entrapment at the elbow. So it's mainly by the either the injury, because it is most superficial. So it's maybe the injury, or sometimes if there is the any bony fragment enlargement, or sometimes there is the loose bone tissue, or some spur rises from the elbow joint. This causes actually the decrease the area where actually passes the ulnar nerve. And another is the synovitis, or sometimes the tumor, ganglia, hematoma, sometimes the ligamentum, inflammation and thickening. So sometimes the muscles, accessories muscles, um, anconeus, epicondylitis, this sometimes may be the enlarged, and sometimes there is the dislocation of the nerve. So these relative actually causes, actually this causes actually causes the cubital tunnel symptoms. So the medial elbow pain, numbness and tingling sensation in the little finger, and weakness of the intrinsic muscle. And here also the very important things, if there is the any numbness, tingling sensation and weakness, always find out the nerve that's come from the spinal cord. So here the T1 nerve and C7 nerve also find out if there is any pathology in there. So you have to correct it, these things also. Now, so the cross sectional, there is the if this cross sectional is more than 10 millimeter square or higher, so the sensitivity of this problem, like the suppose this cross section is the 12 millimeter of square, so the probability of cubital tunnel symptoms is higher. Okay, if there is not more than 10, so you have to actually find out, or you can do the MRI to find out that if there is any C7 or T1 radiculopathy either present or not. Okay, then the radial tunnel symptoms and the posterior interosseous symptoms. So actually here very important part, that is the posterior interosseous nerve, because just it comes between the muscles, between the two muscles, and it's one is the superficial and deep is the supinator muscles. So in between to these, when actually posterior interosseous nerves come, or it is a transitional part, so there may be the compressed or entrapment, or like this. So it may be either the causes actually it causes the compression and causes the distal symptoms. So most probable cause in case of the anatomy, you can see the proximal tendinous edge of the supinator muscles, or we can call is the arcade of the forehead, and the edge of the extensor carpi radialis brevis muscles, and distal ligamentous margin of the supinator muscles. So, see these three things, but most common is the supinator muscles, usually the proximal part, and it is called the arcade of the forehead. So it may be due to the any A space occupying lesion like the trauma, ganglia, or bicipital, or even in the bursitis also. So proximal recurrent radial vessels, if there is any vessels, even in the facial bundle and the radial head. So sometimes the systemic effect may be also affect these area, like the either the diabetics, rheumatoid arthritis, polyarthritis, like this. So these deep muscles actually, when actually cross this area, maybe they entrapped, and the um, posterior interosseous nerve symptoms may develop, and the symptoms are like the numbness, tingling sensation, and not working for the long time. So another very important part. So like here is the pain, so lateral elbow. So here is the one important muscles, that is the brachioradialis muscles. So sometimes there is the myofascial pain, or the uh, bundle is there. Sorry, some muscles taut band is there. So it may be sometimes mimic, but in case of the myofascial pain, there is no numbness and no tingling sensation. So this is the very important clue. And another one, the C5 radiculopathy, sometimes the part of the C6 radiculopathy may also affect this area. So always you should actually correlate both clinical uh, presentation and clinical examination, and also the some investigation. So now the part of the some bursitis, like the olecranon bursa is a very common, and many of the time we have found these things, and it is the just posterior part, just we can feel the bursa, because there is some bursa over our either the joint or muscles, and there's more than 250 or 70 bursa in our body. So many of the time, if there is the direct trauma of the posterior elbow over the hard surface, so it may causes the inflammation of the bursa. Sometimes if there is any inflammation, like the any inflammatory disease condition like the rheumatoid arthritis, or sometimes the peripheral spondyloarthropathy, so it causes, even in the gout, it causes the olecranon bursitis also. So is the swelling, pain, and if there is inflammation, so you can just there's the worm. If there is the any infection, there is the worm, and on the and also the redness over the skin, because it is very superficial, and the repeated movement is the causes. And another one is the infection, trauma, and sometimes the pressure over the elbow, just over the hard surface, so it may causes the bursitis also. So this is the bursitis, and how can you just give the injection, just aspiration of the fluid from the bursa, and after that, if there is any inflammation, you can give the small amount of the steroid, like the 10 or 20 milligram of methylprednisolone, you can give in for this patient. Okay, so now the cubital bursa. So cubital bursa is not a single bursa, there is the two bursa, but most commonly actually affected the um, bicipitoradial bursa, because uh, where actually bicipital tendon inserted, the tendinous part actually inserted in the radial tuberosity. It's just like this, located in this area. So the friction, so multiple trauma or repeated overuse, or repeated mechanical trauma or overuse this tendon, so may causes the inflammation or collection of the bursa, especially the bicipitoradial bursa. So there is the pain, worm, swelling, and it's due to the repeating organ infection and trauma are the same. And cubital bursa, you can see there is the biceps tendon. Here is the actually not seeing the bursa. Here is the you can see the bursa, inflamed bursa, and collection of the bursa. So now the biceps tendon, where actually inserted is this, there is a two fascicle, but the most important actually pathological part is the either it is the tear or non-tear, acute or chronic, or partial tear or full thickness tear. You can see by the ultrasound. So here it is the it's not the very good picture. So yes, we can see there is the thickening. So this is the thickening area. So this is the distal biceps tendon actually thickening. So this is called the tendinosis. Okay. Here actually the tendon is not seen completely, but you should need the maneuver like the heel toe maneuver or like the cobra position. You have to see this tendon is the either complete or not, because actually when you give the opinion like it is the full thickness tear, that is a very crucial things. If it is a partial tear or tendinosis, so you can just um, treat by yourself. If there is the full thickness tear, that times need to the surgical intervention. Okay, so in the cut section we can see the biceps tendon. This part is the normal, but this part is the looking hypoechoic area and the swollen. So this is actually the abnormal part. Okay, now there is the rupture and actually retraction part we can see in this image. So here if we are we know that this is very difficult to inject of the long head of the distal head of the biceps. So here I have shown a video where actually this is the long tendon, this is the long tendon. So needle is like this, so it pierces and gives the medication over here. Okay, so you need the some maneuver. Sir already said that there is the some weight like this just given, and the tendon is the parallel to your ultrasound probe. So you can see and identify the distal end of the biceps tendon, and you can give the injection very finely. Okay, so some tendinosis like the tendinopathies, like the some tear like the complete partial, and sometimes there is the avulsion fracture also. Okay, so it is the lacertus fibrosus. So this is the part of the lacertus fibrosus. Under it the median nerve is come. So here maybe the here we can see the under the lacertus fibrosus the median nerves comes and goes down. So there is the actually chance of the entrapment in this area. Okay, there is some myofascial like condition like the Anconia symptoms. So one very important things for the myofascial pain, number one, it is very localized area, not it's affected a lot of area, it is very localized area. Number two, there is the some trigger point. So when you actually palpate the muscles where actually taut band formed, just pressing or a small amount of stimulation, it causes the huge pain. So pain like this, pain. So this is the huge pain. So number three, in the resting condition, if there is not stressing of the muscles, usually not pain generated. If there is the stressing, like if you are working like these things, or you are just taking some weight, so that time actually stressing of the muscles, so that time actually causes the pain. So these few things is common for all over all myofascial pain. Okay, so another one things that is it mostly the chronic. So usually the micro trauma and the muscles are affected, and there is that some muscles fiber they actually convert it into the taut band. So this taut band, when is it actually stressing, that time actually causes the pain. So I am not talking too much about these things because this myofascial almost the common, but very important, that is the area. Supinator muscle also the affected. So this is the part of the area where actually supinator muscle is located. So you need to the palpate if there is any area where actually huge pain. So that's maybe the affected taut band area of the myofascial pain symptoms. So brachyradialis, so it's just lateral side of the elbow. So sometimes it may mimic with the lateral epicondylitis. Sometimes it may with the posterior interosseous symptoms. So sometimes it also mimic with the radiculopathy. But few things you have to need. If there is any numbness, if there is any tingling sensation, then it's towards the nerve problem. If there is not like these things, okay, so that times you have just thinking about like the brachyradialis symptoms or not. If there is any special point, there is the brachyradialis is highly tense or highly painful, that's maybe the brachyradialis. But in case of the some maneuver, like Mills test, Cons test, it causes the pain. So that times actually in your clinical examination, that times actually you are thinking about the lateral epicondylitis. Okay. So triceps muscles, there is the already sir said that about but there is the three part, there is the medial, lateral, and the long head. So actually there is no especially common area is affected, but it may be the because it is the huge muscle, so sometimes it may be the affected. So many of the time there is the olecranon bursa also affected in these types of the problem. So we need to the ultrasound and that planning for this. So the all myofascial problem, we can treat it like this. The number one is the physical therapy, like the uh, stressing, relaxation, and strengthening, these three parts. Then the our part, like the intervention part, like the dye or wet needling. And the third part, that is the trigger point injection. Okay. So fourth, we can give the dextrose prolo injection for the myofascial pain symptoms. And another is the just spray or stressing of the muscles. That is this forceful stressing over the trigger finger. It causes the actually loss of the uh, trigger point. But sometimes there is the active trigger point. Some there is the um, um, not active. Actually, there is the mm, so this active trigger point you can just find out, but latent trigger point you will not find out by this uh, uh, when you actually palpate these things. But when you give the stressing, just you can just find out the latent uh, muscle taut band also. We can go for also the cool laser, like the low level light therapy. This actually uses by the uh, physical medicine peoples. And the ultrasound therapy, we can also give the ultrasound therapy. And sometimes we can use the TENS, sometimes we can give the acupuncture, and sometimes we need to the CBT do if pain is the for a long period. So so there is the some central reorganization. So and just mental cope up. So it need the sometimes the uh, uh, just CBT is very important. So thank you for patience sharing. If there is any questions, please ask me directly.
Nice presentation, Milton.
Yes, Milton, it was nice. And any question you can ask. Okay, so no question from you, and it was a nice explanation. So next day is your wrist. So wrist, elbow, and forearm. Basically, forearm half we have included today. Next day, when we'll be talking about the wrist, that time also will be including the part of the forearm as well. And pathology also will be next class. Also will be by Dr. Milton. So thank you very much. Go through the recordings again and again. Kahoot already I have posted. So go through the Kahoot as well. The questions are mostly from the whatever we have discussed. And I hope you all are enjoying these classes. And if you are having any feedback, you can go into the chat in the website. Website part, there is a chat part where you can communicate with us. So there, myself, Dr. Chinmay, not Chinmay, sorry, Dr. Milton and Dr. Series is there. So if we are putting there in the chat, so we are going to answer anything in there. So please use the chat part of the website. You can go to the website and you can put the chat and ask us the questions or anything else, not just related to the courses. If you are having anything else also, you can put there on the chat in the website. Website, there is a chat button. Please use that, and you can, that is the way to communicate with us directly. Okay, thank you very much. And
Thank you.
good night.
Great.